All right, let's go ahead and get started. I'm going to say good morning and welcome to Ask the Experts, a conversation hosted by SCAD Alliance. I'm Rebecca Freeman. I'll be moderating and leading the conversation today. And I'm a board member of SCAD Alliance and two-time SCAD survivor. So if you're new to SCAD Alliance, we are a nonprofit organization founded by survivors in partnership with leading cardiologists and health advocates to advance the science of SCAD. So in addition to our independent multi-center iSCAD registry, one of our main goals is to support patients and families. And as part of that, we've developed this monthly webinar series, Ask the Experts. We hope to offer support and education to survivors and caregivers by engaging in conversation with experts on SCAD-related topics each month. So be sure to check out our past webinars, which include everything from PTSD and exercise to FMD and genetics, hosted on our website and YouTube channels. So today we're talking about migraines. Is there a relation to SCAD? What is that? What meds are okay? What research do we need? So the disclaimer I start with every webinar is that while lots of progress has been made in SCAD research, we don't yet have a huge data set to make firm recommendations that apply to every patient. So the information presented today is based on the experience and expertise of these physicians. So please be sure to talk to your medical team about specific plans for your care. More research is coming. Our iSCAD registry currently has 17 sites across the country and over about 650 patients enrolled, which is really exciting, as the more people who enroll, the more we're able to have large cohorts with solid data. So let me start with introducing our amazing panelists for today. First we have Dr. Tsiaras, who is a board certified cardiologist at Massachusetts General Hospital in Boston. She's a member of the integrated SCAD care team and specializes in echocardiography, non-invasive cardiology, and general clinical cardiology care. She's one of the primary cardiologists caring for and enrolling SCAD patients in the iSCAD registry at MGH. So thank you so much, Dr. Tsiaras, for joining us. And Dr. Deena Kuruvilla is a board certified neurologist and headache specialist and director of the Westport Headache Institute. She's held clinical appointments at Yale University School of Medicine and conducted research on medical devices, complementary and integrative medicine, procedural approaches for the treatment of headache disorders. So we're so glad to have you here today, Dr. Kuruvilla. And Dr. Anno Duffy is Associate Professor in Neurology, specializing in stroke and headache at Vanderbilt University Medical Center. She's board certified in neurology and vascular neurology, and she's an attending physician in stroke and general neurology at Vanderbilt. Her research interests focus on diagnosis, management, and prevention of cerebrovascular disease, as well as stroke and headache in women. So we have a great group today to discuss this big question of migraines. We've had so many great questions submitted in advance for our panelists to discuss. And looking through, there were really two clear themes to these questions. First, the relationship of migraines and SCAD, and also treatment options. So we're going to use that to really structure the discussion today. We want to start with the question of, are migraines and SCAD related and how? So many people, we had lots of questions asking, mentioning either an increase or decrease in their prevalence of their migraines after SCAD. Some people had migraines the day of their SCAD. People wondering, if that's a vascular or neurologic or what sort of component. So what we'd like to do is start by going around and having everybody give some background. What we know with that big question. So we want to start with Dr. Kuruvilla, and then we'll work our way around. Thank you so much.
Thank you so much, Rebecca. So we definitely know that patients with SCAD are more likely to have a history of migraine. One large survey registry study showed that around 40% of people with SCAD had a history of migraine. It's unclear based on the existing research what that relationship is, if they share some type of mechanism that underlies both conditions that makes them related. It's unclear. But what we do know is that some of the medical conditions that exist with SCAD more commonly also exist with migraine. Some of the conditions that are more common that are associated with migraine are depression, sometimes some inflammatory disorders within the body. Those are just two examples, and sometimes those related medical conditions can make them more commonly related. We also know that both conditions predominantly affect women. We know from many migraine studies that migraine is much more common in the female population, and we've seen something very similar in the SCAD population. So some of these shared demographics and shared medical conditions could certainly highlight that relationship. Yeah, I can also talk a little bit about primary and secondary headache disorders.
Yeah,
because
that'd be great. Kind of defining too, kind of what is a migraine? We see there are definitely some questions on, yeah, that what is a migraine too piece.
Right.
Is that the same as having a headache? There are
Right.
different types of migraines. How does that play a
Right.
role?
Yeah, so we can't dive into that without answering that first question of what is a primary headache and what's a secondary headache. So primary headaches are basically the pain, the headache is caused by a headache disorder, of having a primary headache disorder such as migraine or cluster headache or tension type headache. And we think that migraine specifically is caused by an activation of inflammation. One of these big components of that activation of inflammation is calcitonin gene-related peptide, and the release of calcitonin gene-related peptide not only has that inflammatory effect, but it has an effect on the blood vessels of the brain as well. And so that's kind of the thought behind migraine. So migraine, tension type headache, cluster headache, they're all primary headache disorders. So secondary headache disorders are those headaches that are not explained by a headache, one of those headache diseases I just highlighted. So secondary headache disorders, there's an underlying cause for those headaches, such as tumor, such as dissection in one of the arteries of the head or the neck, such as aneurysm in the head or the neck, such as bleeding within the head or the neck. Those are all other underlying medical conditions that have then caused that headache. And how does all of this relate to SCAD people with SCAD? So the first thing is, I would have to say that we talked about migraine being more common in the SCAD population. So it's certainly one of the considerations when we see patients, people with SCAD, screening them for migraine, making sure that they don't have a secondary cause, any underlying dangerous causes for headache before we give that migraine diagnosis. So, migraine is certainly a consideration. The other side of the coin is those secondary headaches. So we know that the carotid arteries, the carotid artery is an artery that stretches through the neck and then moves into the head, can be affected in SCAD patients. Some of the research showed that it's the second most common artery that's affected. And so sometimes we see headaches of variable types of headaches associated with a aneurysm or dissection of that carotid artery between the neck and the head. So that's certainly something to consider. So there's definitely utility in differentiating secondary causes for headache and those primary causes for headache. We always only go to diagnose that primary cause for headache, like migraine, after ruling out those dangerous causes.
So that makes sense. And I want to kind of segue right in with Dr. O'Duffy, since you do a lot with that cerebrovascular, that stroke and headache talk. So I'm hoping you can speak to that as well. And also maybe some of the pathology of that, some of that, what is that inflammation piece related in patients, specifically in patients who have migraine,
Okay, so sure. Yeah, so I specialize in cerebrovascular disease, and headache. So I do tend to come across this overlap and questions related to it frequently. And I'd have to say, echoing what some of the things that have been said, is that we're really, I would say, beginning to understand these things, and we still have to treat patients, as individuals, and come up with, a proper diagnostic and therapeutic plan, based on an individual's particular situation. But I just wanted to see if I could share my screen, which I thought I had. I thought I had this down, but is that,
perfect.
can you see that now?
Yep, that looks great.
So I just wanted to cover a few concepts to do with this this kind of migraine and cerebrovascular disease overlap. And, there's been a lot of data, a lot of studies over the last 15 years or so that we pretty much have to face that that just having migraine, particularly migraine with aura, is a risk factor for stroke, for cerebrovascular disease. And there, been thousands and thousands of patients in various studies that have come to this same conclusion. And so, sorry, I'm just not scrolling properly. So basically, we think that this cortical excitation that happens in migraine may also generate alterations in blood flow that could lead to tissue damage and stroke. And so I guess I would think of it as kind of shared susceptibilities, because, we see all range of cerebrovascular disease and migraine overlapping. So, other examples, kind of uncommon things, but CADASIL and MELAS and familial hemiplegic migraine. There's genetics at play, and these are very different conditions with different manifestations, but that all seem to have this increased risk of migraine as well, as does SCAD, as does other acquired thrombophilia conditions like antiphospholipid antibody syndrome. So, we're trying to understand how, what are the mechanisms here that may be in play. And so, just seeing this kind of busy slide, I'll just preview by saying, we really don't know 100% the answers, but, is it, do we have more sort of active reactive arteries in migraine? So is there this vasospasm component where we have release of vasoactive chemicals that play a role? Is there endothelial dysfunction? Is there platelet activation, aggregation, and or other procoagulant factors in play, such as, as I mentioned, the antiphospholipid antibody syndrome? And so, there are lines of evidence. This is just a paper that kind of is really trying to nail in or discuss what we know about the association between migraine and cerebrovascular disease. But this is just another little bit of data about migraine with aura being an independent vascular risk. I'm sorry, I just wanted to, and so this is another interesting sort of facet of this. Do people with migraine have abnormal blood vessels? And so people have studied sort of the stiffness, you could say, of the aorta with this aortic pulse wave velocity type studies. And it does look like young people with migraine have, stiffer aortas than non-migraine people. And this was found especially in people with migraine with aura, again, which, is maybe a different disease, maybe a different thing than common migraine without aura. But so, this is just a little clue, a little idea that is migraine linked to impaired endovascular function that isn't just restricted to the cerebral arteries, but more widespread. And so these were just some concepts or just some ideas that were running through my mind. I think we probably just don't want to get too far into the weeds here. But I think there are a lot of interesting threads, of research about all these issues. It is very interesting that we're sort of, just sort of getting to these studies and in these conditions that are far more prevalent, in women. But, it's really nice to see my fellow, women experts in these conditions.
This is great, Dr. Duffy. I have, so it seems like some of these studies definitely show this relationship of migraine being a risk factor for possibly changes in the vasculature, including stroke and things. Do we know from the other way? So if somebody has had SCAD, or maybe, one of your patients has had stroke, are they more at risk for migraines? Or do we know that piece yet?
I think that's really variable, as in some of your literature. I mean, some people who had a history of migraines, stop having them after they have their SCAD episode, and is that because something's changed with the physiology, or is it because they're on beta blockers and so they're really on a preventative regimen for their for the migraines as well as their heart disease? I would say in general, it's under-recognized or appreciated how much headache trouble people have who have stroke. So especially in the acute, subacute time, younger people, women, people with a history of migraine, we, fairly often we see headache problems after the stroke. And, this obviously leads to challenges because, do we know that their underlying cerebrovascular condition is stable? Is something changing? Are they having bleeding? And then, as I think we'll probably begin discussing, the treatments then are do we have to change our treatments based on the new vascular events like the SCAD or the stroke? And the answer there is absolutely. I think we do have to change what we, how we treat.
Right. Right. And we'll jump into that. It's like, Dr. Tsiaras, since you're the one who sees SCAD patients. So I'm wondering, we've heard kind of from a neurologic standpoint, what we know about this predisposition. But what about, when a patient had SCAD, kind of how can you help translate this into how, how that guides, the patient who's already had SCAD and where we should be thinking about this,
Sure. Yeah, I'm happy to. And actually, I think a lot of what has already been said is a good foundation for sharing my own thoughts. So thank you for including me here. And I'm grateful to be part of this panel. This is a really important topic because, as has already been said, migraines are very common in our SCAD patients and more common in SCAD patients than in the general population, which leads us to think that these two conditions are linked. And as has already been said, it appears to be related to abnormal vasculature in some way. I think, when we take care of SCAD patients, we typically, our practice at Mass General is to screen for extra coronary vascular abnormalities, and in particular, the condition of fibromuscular dysplasia. And part of the reason when I explain to patients why I'm doing this screening is because I don't want to miss a cerebral aneurysm. So what we know from screening our patients and from a lot of studies is that FMD is seen in probably up to 60% of people with a history of SCAD, or if not FMD in particular, some other sort of abnormal arteriopathy. We don't always call it FMD. Sometimes we find small dissections in other vessels that don't quite meet criteria to be FMD. But one of the reasons to emphasize the screening for FMD is that, up to 10% of people with FMD could have cerebral aneurysms, and we don't want to miss that. So that was something Dr. Kuruvilla said, and I think is important to mention before we jump to the diagnosis of migraine. But with respect to migraine, I think that the question that was asked, that was a really good one, is, what is the relationship between migraine and SCAD? And I think it's important to say that I don't think one causes the other. I don't think there's causality just because there's association. And I have a slide to just sort of give a picture of this, or sort of how I understand the relationship. So I'll just share my screen here. Can you all see that?
Mm-hmm.
So this is from a recent SCAD review last year by the group in Mayo Clinic, but the circle here on the top just shows, in the middle is the SCAD, which is the primary population that we're looking at, but then all the other overlapping conditions, and including the migraine up here. So migraine, FMD, other connective tissue disorders, genetics, and then I think hormones probably do play a role. I think that was a question that was asked. The reason we believe that is because, as has already been said, this is much more common in women, both migraines and SCAD, which leads us to conclude that sex hormones probably play a role. In addition, SCAD has also been associated with pregnancy, and in the peripartum period is another time where we see higher rates of SCAD. So that leads us to think that hormones may play a role, and I'll leave to the neurologists in our group to discuss that, but I think there's probably an association with migraines as well. And as has also been said, sort of emotional stress, depression, other things which are sort of common risk factors. One of the other sort of underlying conditions, and I think this in this circle you can see susceptibility genes is listed. There has been some recent interest in common genetic abnormalities, including, I think, as Dr. O'Duffy alluded to, sort of the endothelin gene, which has been linked to basically many vascular conditions, including migraine, dissections, atherosclerotic disease, and SCAD. So it's not particular to any one condition, but I think if you have this susceptibility allele, you're more predisposed to some of these conditions. In terms of whether that is useful clinically for screening, it probably isn't, for mainstream diagnosis now, because that abnormality can be found in up to 50% of normal people. It's just enriched and is probably found in about 70% of SCAD patients. So again, sort of an underlying predisposing condition, but not necessarily causal, so to speak. And from what we know, in the migraine versus non-migraine patients, there doesn't appear to be an increased risk of SCAD, whether or not you have migraines. Which is reassuring, I think, to those who may be on the webinar here and worrying, are they at increased risk of having SCAD because they have migraine headaches? I don't think that's the case. And then I think I'll leave to sort of the next part of the discussion. I think there's treatments that we have for SCAD, like beta blockers, which are probably helpful for migraine, as has been suggested, and we know definitely to reduce the risk of recurrent SCAD, so that's in our favor. Other things that sometimes are used to prevent chest pain after SCAD, like nitrates, can also conversely be harmful, I think, and cause increased risk of migraines. So I think there's a lot of interplay here and a lot of implications for treatment in patients who have migraine and SCAD. And finally, I think interestingly, patients who have migraine headaches do seem to have more chest pain after a SCAD, and whether that's because they can't use nitrates, which can be helpful, or whether it's just more abnormal vasculature or active vasculature, I think is not clear.
Makes a lot of sense. Dr. Duffy, did you want to add something to it? I saw you smile.
No, I just.
Okay. One question I wanted to kind of pull up. So Dr. Tsiaras, you mentioned, maybe not directly, like, okay, you have migraines, you have SCAD. Is this a long-term relationship we're talking about between, migraines being a risk factor for things, or kind of short-term? Somebody mentioned the question that they had a migraine the day of their SCAD event. Could that be a trigger, or are we talking more on the long-term?
I would say, could it be a trigger? I mean, could the stress of a migraine and the pain of a migraine have driven up blood pressure or triggered some, acute, very, stressful event, or maybe vomiting or something else that actually could have triggered the SCAD? I can't rule that out. I think because migraines are very common and SCADs are uncommon, it's not, you could have a migraine one day and not have a SCAD, and then have the migraine another time and have a SCAD. So I can't exclude that there was some relationship, but I also don't think that you could prove it. and then some of the, medications that are taken for migraines, like a triptan medication, could that have driven up blood pressure and triggered a SCAD? It's possible. But again, I think it's more the shared vasculature sort of abnormalities. That's probably the link between the two rather than one causing the other.
Makes sense. And I'm glad you still have this image up just as that reminder that there's so many factors that can impact having a SCAD event too.
Sure.
We don't have this caused this, but I remember when I was first diagnosed, it was, that discussion of like perfect storm, so many things.
Yeah. As you can see here, sort of the red circle around the outside is kind of all the environmental things that may be playing a role. And then the gray circles on the inside are kind of the sort of the patient conditions that may predispose to these triggers causing an event. So with that, I'll stop sharing, but I can always pull it up later.
Yeah, that's great. Oh, and then also, to neurologist, Dr. Kuruvilla, or Dr. Odefi, you mentioned that hormone perspective, that hormone component. Do we know, is there a relationship with migraines and hormones? And is, both just, endogenous, but also exogenous, somebody's taking, oral contraceptives or.
So there's certainly a relationship between hormones and migraine. We have specific migraine subtypes that are hormonally related. For example, we have menstrual migraine and we have menstrually related migraine. So there are some folks that we see who have migraine headaches just a few days prior to their period or during their period or immediately post-period. And typically we blame those migraine headaches on a sudden drop in estrogen. Fluctuations in estrogen or sudden fluctuations in estrogen have been shown to be pretty big triggers for migraine, either with just triggering migraine attacks or at times making migraine more frequent. And so, another menstrually related migraine is having that hormonal component for migraine, having those headaches around your period, but also having headaches that are not related to your period. So we have specific terminology in the migraine world for these migraine attacks that are related to hormones specifically. And the biggest culprit that I've seen is that sudden drop in estrogen. One interesting topic that I've seen in clinic lately is my patients who are going through in vitro fertilization because they're needing to take treatments up until they have implantation of the embryo, for example. And so a common question I get is, are these treatments, hormonal treatments, contraindicated in people with migraine, and do you foresee migraine getting worse as a result of these hormonal fluctuations? So my answer is yes, migraine that migraine disease will likely get worse as a result of those hormone fluctuations, especially those fluctuations in estrogen specifically. And I also kind of highlight that we know that estrogen, especially above a dose of 20 in patients with migraine with aura, is not recommended due to that increased risk of stroke.
It makes sense. What about kind of just as we're talking about these relationships, there was a question somebody sent in about genetics with, I know we may not have a specific genetic, a gene that we're looking for, but if there's a family, say, a mom had, grandma has migraines, mom had a SCAD, child has migraines, is that child need increased just monitoring for SCAD? Does that whole family kind of need increased monitoring for SCAD? Where will we, or other conditions, what do we know?
I think, one really, really tricky point I should bring up here is that 40 million people in the United States have episodic migraine. Episodic migraine basically means folks who have less than 15 headache days a month. And 4 million people in the United States have chronic migraine. So those folks who have chronic migraine have 15 or more headache days a month. And so that it's so difficult to say because that epidemiology Migraine is just so much more common among the general population in the United States. In my clinic, I'm not routinely screening patients for other vascular disorders unless there's a specific clinical concern. If they're giving me symptoms that are related to a cardiovascular issue, unless they're giving me some specific clinical red flags, I'm not routinely screening them. I really, really believe in a strong partnership with cardiology. Anytime I have any doubts about a patient's presentation or a screening question, I often partner with my local neighborhood friendly cardiologist and they help me out.
Mm-hmm.
Yeah, I would say in terms of genetic testing for these, we have a cardiac geneticist who we work closely with. I think Dr. Mark Lindsay was on one of these prior webinars, so you can refer back to that probably for more detailed information. But in terms of the utility of genetic testing, we almost always offer it to patients, just I think if there's a concern, and particularly patients where there's any family history of other vascular diseases, whether it's aortic aneurysm or dissection or something that would make us really worried about one of those underlying connective tissue disorders that really places patients at increased risk. And those fortunately are rare. So I think finding a genetic mutation in one of those, something like Marfan syndrome or Ehlers-Danlos, the risk of that is about less than 5% in the populations that we screen. And then these other, less less potent genes that I just was referring to, like the endothelin 1, that's just so common. And even if you had the gene, it's still very unlikely that you would develop SCAD. So I think that's less useful.
That makes a lot of sense. Thank you. And I think that brings up several good points too of where, the populations that each of you are seeing too, Dr. Kuruvilla mentioned, I'm glad you mentioned too, that just that prevalence, that very high prevalence of migraines.
Mm-hmm.
And so.
And remember too, just one other little point, migraine basically behaves as a dominant trait. So it's going to be in families, and sometimes we find that the proband, the patient that we're seeing allows, diagnosis of migraine in a parent, who was never diagnosed before. So, it is very common. And I agree that unless there's a red flag or somebody, in said family had a cerebral or a vascular event, whether it's a cerebral aneurysm, an SCAD, what have you, then I don't routinely screen regular sort of migraine patients either. So, but if they have a significant change, right, we always have to remember that if there's a significant change in people's symptoms, type of headache, frequency, severity, if there's something associated neurological symptoms, these would be the kinds of things that would lead us to kind of broaden our, differential and think, well, what else could be going on here? Because I have seen over the years that error made, I guess, is that when somebody has a history of migraine, they get kind of tagged with that. And so then everything and anything, oh, that's just the migraine, so we have to be very careful to establish, the clear history. And is this different or is this the same as migraines that you've had before?
That makes a lot of sense. I want to shift gears, well, maybe not shift, but shift a little bit into treatment. We got a lot of questions, a lot of discussion on, if patients, what can work for treating migraines? I think this is probably a big question just for all your migraine patients, but especially, patients who have had SCAD, and we can start off probably with one of the neurologists kind of on a general overview of, approach to treatment of migraines, and then we can get into what considerations for cardiologists or for SCAD patients specifically.
Yeah. So the great news is that there are so many treatment options now for the treatment of migraine. There's a couple of different approaches that I take when I recommend treatments to my patients in clinic. According to the American Headache Society, if someone is having 4 or more headache days a month, or any headache with disability, we have to, it's important to offer them a preventive treatment for migraine. So the first point here would be prevention. At the moment, we have daily oral medications, we have monthly injectable medications, we have procedures that have all been found to be useful for the prevention of migraine. Some of these preventive approaches are blood pressure medications, beta blockers, which Dr. Tsiaras had referred to earlier, antidepressant medications, seizure medications. Those are the 3 big groups of medications that we use to prevent migraine and our oral daily medications. We also have botulinum toxin, Botox, which we inject every 12 weeks for the prevention of chronic migraine if folks are having 15 or more headache days a month. And more recently, over the last couple of years, we have a new FDA-approved family of medications called the CGRP monoclonal antibodies, the calcitonin gene-related peptide monoclonal antibody injections. There's 4 of them currently available. 3 of them are monthly injectables. One of them can also be used as a quarterly injectable, and were found to reduce migraine attacks by 50% over a monthly period. These injectable medications are FDA approved for episodic migraine for folks who are having more infrequent headaches, and in folks who have chronic migraine, so the folks that are having more frequent headaches. So 3 of them are injectable medication, and the most recently FDA approved one is an infusion that is given in the comfort of an infusion center or your doctor's office through your vein. And it's infused every 12 weeks. It also showed around 50% reduction in the migraine frequency and severity. So definitely preventive approaches are something to definitely discuss with your doctor if you're having 4 or more headache days a month. And then the kind of second point is acute treatment. What do I do when I get an attack? We have a few different categories that have good evidence for that acute treatment of migraine. Non-steroidal anti-inflammatories we commonly recommend for patients as needed. Medications such as naproxen or nebumetone, diclofenac potassium, those are all non-steroidal anti-inflammatories. We use anti-nausea agents like metoclopramide because it has evidence not only for breaking the migraine pain, but also for treating the nausea that may be associated with that migraine attack. One of our tried and true treatments for migraine that's been out since 1990 are the family of triptans. There are 7 different available within the family of triptans. But one of the positives is it's a potent medication used for the acute treatment of migraine. One of the downsides is it should not really be used in people with a history of coronary event, heart attack, stroke, uncontrolled diabetes, uncontrolled hypertension. So we often try to avoid the medication in people with SCAD due to the fact that it could cause a vasoconstriction of the blood vessels. So the triptan family option as an acute treatment should be really, really discussed with your doctor, and should not really be an option if you have a history of SCAD or other cardiovascular event or cerebrovascular event. The newer acute treatments that were FDA approved are one family called the GPANs. They were just FDA approved in February of 2020. The GPANs are rimegepant and ubrogepant. They specifically block calcitonin gene-related peptide. They're tablets that can be taken as needed with your migraine attack, and they are not contraindicated in folks with a history of cardiovascular events, history of stroke, or any of the same contraindication. They don't have the contraindications that triptans have. So they basically work to block that inflammatory circuit, block calcitonin gene-related peptide. And the last one that was recent, that was FDA approved around February of 2020 is a ditan. It's lasmiditan. So it's kind of a new age triptan that works very similarly to the triptans, but does not work on the serotonin receptor that causes vasoconstriction, that causes constriction of those blood vessels. So lasmiditan is a newer agent that can be taken as needed for a migraine attack, new age triptan that doesn't have the same vasoconstrictive effect, but does have some other issues. Lasmiditan is a controlled substance, and folks can't drive for 8 hours after taking the medication. So, there's definitely some give and take with these acute migraine treatment medications. The third kind of tier of migraine treatment approaches that I get asked a lot about from patients is the natural approaches. What are the natural integrative medicine approaches that I can kind of add to these mainstream approaches that my provider is recommending? So there are vitamins that have been studied specifically for migraine, such as magnesium, riboflavin, coenzyme Q10, feverfew, melatonin. These all have some utility as an add-on treatment for what your doctor may be doing for migraine prevention. There are some studies available on other non-medication approaches to management, such as mindfulness, biofeedback, meditation, yoga, exercise. There are so many studies coming out that show that these approaches, if added onto mainstream treatments, can really, really give you the best bang for your buck. So those are kind of that's kind of the three-tier approach that I take to migraine management.
That's awesome. Thank you for that, super comprehensive going through it. I want to pass to both Dr. Duffy and Tsiaras, where the patients you guys see and other considerations.
Sure, I can go. So, that was a great overview, and I'm happy to hear about these sort of newer agents. I haven't actually seen a lot of patients on those newer medications, and that may be in part because they're so new, and I don't know what the sort of approval process is like to get those through insurance. Sort of as I reviewed it, it seems that there are some receptors for the CGRP that you referred to on the blood vessels. And so I think even though a lot of the studies using that medication did include some patients with heart disease and found no adverse effects, I think, those studies invariably probably did not have a lot of SCAD patients, or else we just may not know how many SCAD patients were included in those studies. So I think the safety of it is a little bit uncertain. And I think you could imagine if there are receptors on the coronary arteries, that it could potentially affect sort of, especially endovascular, the endothelial function there. So it seems to me that it's potentially a really good option. But I think still a little bit unknown and unstudied. And I would say if these medications are used, which I think they would definitely be safer than the triptans, which I have a concern about in SCAD patients, I would just monitor for sort of whether there's any chest pain symptoms around the time of taking those medications, and definitely stop it if that seems to occur. It doesn't seem that they raise blood pressure, which is, something that we also worry about in SCAD patients, and one of the reasons to avoid the triptans. The other class of medications, and it sounds like, this is not something that you typically do, Dr. Kuruvilla, but we usually like to avoid exogenous hormones in patients after SCAD just because of the concern about risk. And so, I know some patients have been on hormone therapy for prevention of migraine headaches, and that's usually something that we like to discontinue, though then we do have the concern of making the migraines worse and then dealing with acute treatment of migraines afterwards. But also on the good news, as you said, beta blockers have definitely been shown to decrease the risk of recurrent SCAD. We love them, and if they're helpful in migraines, then I think we're getting 2 for 1 in that deal. And then finally, as I said before, I think nitrates probably should be avoided because I do find they really make people's headache a lot worse.
Dr. Duffy, are there other kind of other considerations you see from, because you work in that kind of joint world with stroke and headache?
Well, I would say that we deal with the same concern about exogenous hormones, in stroke patients.
Right.
And so that may be, in the younger patients, oral contraceptives, but in the menopausal population, hormone replacement therapy. So I think that's something that, that can affect somebody's migraines, and we have to deal with that. But I would follow the kind of guidelines, the recommendation of stopping exogenous hormones in stroke patients. But I think as far as the treatments, these emerging treatments for migraine, I'm really excited about them. And I think we've seen a lot of success with the CGRP monoclonal antibodies, and they seem to work better the longer people take them. So the results just get better and better, and it's just it's been really fulfilling, I guess, to see this finally come to the clinical sort of practice, because we've heard about sterile inflammation and migraine and the role of CGRP for my entire career, really, probably for at least 25 years. But so it's only been in the last 3 years that we've actually been able to manifest with these treatments. And we are using a lot of the monoclonal antibody migraine preventers, and the insurance authorization stuff is a little bit of a challenge, but we've been able to get them approved most of the time, especially after they've been out for 6 months or so.
That's awesome.
We have like 1,000 patients at Vanderbilt that are taking the CGRP monthly preventives. The fourth one, the Vyepti, the IV infusion, we got a little bit caught up with COVID care, and so there's a bit of a delay for getting that one on our hospital formulary during COVID. And so we finally did last fall, and so I've had some good success with that one as well.
Dr. O'Duffy, I know that you see a large SCAD population down there at Vanderbilt with Esther Kim there. Do you have SCAD patients who have been on these newer medications?
I do have some.
Yeah.
And yeah, there's, I would say maybe a handful, and I haven't, had any problem with anybody to date. I have had one patient, not a SCAD patient, but a patient who probably has Prinzmetal's, who has vasospasm, who did have chest pain a couple days after taking her monoclonal antibody migraine preventive shot, and did not report this to me until she'd had it for 3 months. And each time at like day 6, she had terrible chest pain and ended up in the hospital. And we thought that she really should not take that medicine anymore. And she had vasospasm. She does not have traditional coronary atherosclerosis, but
Yeah.
that's just, I think it's one patient of 1,000 that we're treating. But
Yeah. And vasospasm, I mean, it's one of the things that we think may be a cause of sort of post-SCAD chest pain in some of our patients, in particular, because a lot of them respond to treatments for that, although all post-SCAD chest pain is not vasospasm. And I think also, to clarify, I don't think vasospasm necessarily causes SCAD. I think it's more the opposite. I think lots of times SCAD can lead to sort of irritable vessels and then potentially vasospasm afterwards. And then just one other point I forgot to mention in response to the NSAIDs that you recommended, Dr. Kuruvilla. Those are sometimes a concern in our heart population, in particular, because they can raise blood pressure a little bit, and they can interfere with the action of antiplatelet agents. So in patients who have had a SCAD with a recent stent, we usually recommend avoiding NSAIDs. I think, not every patient who's had a stent needs to avoid NSAIDs indefinitely, but I think in the early period, probably the first 6 to 12 months, it's probably safer to avoid those.
That makes sense. Thanks for kind of circling back to that too. Just, I know a lot of, it's an interesting, we talked about kind of the prevalence of migraine, but most of the patients who watch, the webinars or who tune in are the subset who have also had SCAD too. So I'm glad you got to that too. Just a couple other questions that I want to get to before we need to wrap up. So Dr. Tsiaras, you had mentioned a little bit about FMD. Would any of these, in patients who are found to have FMD, so SCAD and FMD, are there other considerations, or would these same discussion points that we've had, for the past hour really apply to those patients the same?
I think the short answer is they would probably apply the same. FMD is so commonly found in our SCAD population. And like I said, we don't always call it FMD. It's sort of arteriopathy, not otherwise specified or not well categorized, just based on the appearance of the imaging of either the, abdominal, pelvic vasculature, the head and the neck vessels that we see. We usually do a CTA of those vessels. But there doesn't appear to be worse outcomes in patients with FMD and SCAD versus patients who don't have FMD and have had a SCAD.
Okay, awesome, thank you. And then another question, a specific question that we got, the patient who has had both SCAD and has intracranial hypertension, and is that, are there specific medications of these that we've talked about that they need to avoid because of that link? Or is that getting down a whole nother rabbit hole?
Yeah, so intracranial hypertension is and the headache related to it in many cases is a completely different disorder. The headache related to it is a secondary headache, and it's managed very differently than we would manage migraine or other primary headache disorders. For example, we use medications such as acetazolamide to decrease the pressure in those patients. And one of the shared treatments for both intracranial hypertension and migraine is topiramate, which can also be used in intracranial hypertension to decrease that pressure. But yes, it's a completely different treatment, different evaluation than we would typically approach for other primary headache disorders.
Awesome, that sounds good. And I'm glad it kind of ties back into that primary and secondary. I think that makes a lot of sense. I'm glad you went through that at the beginning too. So I wanted to give, while we have just a couple minutes, I wanted to give each of the three of you, if there was any additional things that we haven't touched on, or comments that you want to make, or other things we wanted to share, just as a chance before we go further. No, we're all good. Then with that, I'm going to go ahead and wrap us up, because this has been a phenomenal discussion. I think it's one of the things that I always really enjoy as a patient is this collaborative approach with a lot of SCAD care. And so really being able to bring together your neurology and cardiology and all of your different expertise is just really enlightening. And I think it's also really encouraging. Also as a patient, hearing all these new treatments and what's on the horizon. So I am going to have that conclude our Ask the Experts for today. Thank you all for joining us, participants and panelists. This has been, as always, informative and empowering. We record our webinars and it will be available on YouTube. The link will be posted on our social media sites, as well as sent to our email listserv. So if you're not on that yet, be sure to subscribe at scadalliance.org and follow us on social media. And we will see you soon for our next Ask the Experts webinar. Thank you.
Thank you.
Thank you.